Professor Kumar Velu sir for his kind invitation. Good morning, friends. Now we are dealing with a more happier things and more satisfying part of stroke. I am asked to talk about venous infarction beyond pregnancy and puerperium. Okay, let's go through a few cases. This is a 41-year-old male, history of DVT 2 years back and hypertension, came with severe headache and blurring of vision. MRV confirmed CVT. When we examined him, he had a plethoric face, erythromelalgia, and a huge splenomegaly. Labs showed RBC count high, increased hematocrit, and genetic studies confirmed the JAK2 mutation of polycythemia vera. 35-year-old male underwent emergency surgery for acute intestinal obstruction. In the post-op period, he complained of severe headache and through a seizure. And when we did a CT scan, dense transverse sinus and treated for MRV. A 20-year-old young lady just took 2 tablets for her postponing her period for the upcoming marriage and developed CVT instantaneously, and she did have extra prothrombin polymorphism. A 60-year-old man with diabetes, hypertension and past is treated for non-Hodgkin's lymphoma and came with a progressive headache and visual disturbances, nausea, vomiting and some cognitive disturbances. Routine CT was normal, CSF normal. Then we did a MRV which showed a subacute thrombosis of superior sagittal sinus. So these are the scenarios which are not at all uncommon. CVT, though it is in general a less common type of stroke, it is very important to recognize it because it is hugely positive success. However, there has been increased incidence observed in the last decades, once thought predominantly in children and young women and mostly hormone and pregnancy related. Now we know there are 100 and plus risk factors for CVT, and studies from India, one of the highest registries of CMC Vellore and US showed epidemiological shift with increased incidence in older patients and males. It is a multifactorial disease associated with multiple inherited and acquired risks that act synergistically, as the case with the young lady who took just 2 tablets of ticagrelor, the hormone tablet to postpone the tricular, that is called tricular or something. Thrombosis of the veins can include dural venous sinuses or the cortical or deep veins. It has variable symptoms making immediate diagnosis challenging. It can present as acute less than 48 hours or subacute up to 30 days or chronic more than 30 days. We all know subacute is the most common presentation. And it has, we can also remember them as 4 distinct common clinical syndromes like raised ICP, like IAH presentation, focal neurological syndrome mimicking an arterial stroke, diffuse encephalopathy mimicking a metabolic or infective pathology, and cavernous sinus syndrome when it is limited to cavernous sinus. This picture shows you the highest prevalence of sinuses involved, and mostly it is the transverse sinus and superior sagittal sinus, and it is not uncommon to have multiple sinus involvement. And we all know the common presentations are headache up to 80% and seizures up to 50%. And papilledema is very important clue for CVT when you have a non-specific or persistent headache. And if there is a papilledema, always think of CVT. And for the postgraduates, I found this very good slide on, depending on the type of sinus involved, the symptomatology can be point towards that sinus. You can go through it later. And the risk factors are, in general, broadly sex-specific factors, hormone-related, medical conditions, and other factors. Recently, we have been proved that obesity itself can be a risk factor for CVT. And we can also think of the risk factors as transient or chronic. Transient meaning this is important to differentiate because the management only is limited to about 3 to 6 months. When there is a chronic condition, we have to decide about lifelong anticoagulation and the drug of choice. And just to go through a few of the risk factors, it can be a hereditary condition like prothrombotic diseases, hematological like anemia or polycythemia or TTP. It can be autoimmune and inflammatory diseases, Behçet's and SLE being very common causes of CVT, inflammatory bowel diseases in young men, and infections, especially in children, ENT and sinus infections, meningitis, mechanical causes, malignancy, during, after treatment or even before sometimes. Drugs, in addition to contraceptives, there are cytotoxic drugs and even IV immunoglobulins can come sometimes precipitate CVT and miscellaneous like obesity. And our study from India also showed more or less similar profile from Kameshwar Prasad sir's group. And this is the CVT registry from CMC Vellore, which is one of the highest number of registries number in the world itself, and they also showed that the incidence has been increased to 96 per 1 lakh and almost doubled from the last decade, and higher incidence in men and the older people. And postpartum CVTs are coming down. It's good because of the better antenatal care and postnatal care. And this is also showing that postpartum CVT is less in women. They are having non-puerperal CVTs more. And this is the age and gender, the trends which are showing there is a difference in shift. Now it is little more men is little more than women. These are the age group. Age group is also becoming, you can get anywhere from birth to the old age. Any age can get the CVT. The imaging abnormalities are quite typical, not to miss many times. You can have a dense vessel sign, cord sign, dense triangle sign, cashew nut sign, bilateral or multifocal hemorrhages. The CT sensitivity is 80% and specificity is 90%. These are some of the, do you have a pointer here? Yes, this is the cashew nut sign, this is the dense transverse sinus, this is the dense suprasagittal sinus, and these are the thalamic lesions in deep CVT, and this is the cord sign, and multiple bilateral hemorrhagic infarcts is the classical sign of CVT. MRI findings are also very typical, and if the gradient related echo, recalled echo, susceptibility weighted images are very good to not to miss even the cortical veins. Contrast enhanced MRV is very useful for these findings of cortical venous thrombosis, where there is a limited area of thrombus, where we are not sure whether it is significant or not. You have to go with this MR imaging. Sensitivity is 80% and specificity is 90%. So these are the typical signs. These are the bilateral thalamic lesions in deep CVT, bilateral hemorrhagic infarcts in the suprasagittal sinus, and this is a specific sequence of MRI showing the deep, the straight sinus, which is thrombosed. And this is the typical infarct we all see very commonly in the transverse sinus thrombosis. And this is the MRV showing the occlusion of the anterior half part of the suprasagittal sinus. Coming to the treatment of CVT. So this is a very nice flow chart and taken from the German guidelines. The initial therapy is the acute stage, the maintenance therapy, and then the secondary prophylaxis, and what do you do lifelong to that patient. Of course, the initial therapy is anticoagulation is the mainstay. The maintenance therapy usually depends upon the duration and underlying risk factors, and secondary prophylaxis to avoid not only CVT but also other thrombotic conditions like DVT or pulmonary thromboembolism, and what should we advise them during their further life. For example, the next pregnancy and the next screening, what should they do? All these are important. CVT is a lifelong indicator of thrombotic condition. The acute treatment, the most important mainstay of treatment is the heparins, and the LMWX is the most convenient and predictable. All of us give 0.6 milli of LMWX to twice a day up to 5 to 7 days and bridge them with oral drugs. We can also give in poor patients unfractionated heparin, either subcutaneous or IV or infusion, bolus or infusion, all are equally effective. Dovox are also coming up higher in these patients, especially in the follow-up stage. Treatment is heparin is the drug of choice even when the patient has an intracerebral hemorrhage, because that is the cause of the hemorrhage is the CVT. 0.6 milligram subcutaneous, as I was mentioning, overlapped with OSA. No difference in functional outcome and hemorrhagic complications between these two. So you can easily give the NIMHANS protocol is heparin 1 cc subcutaneous 6th hourly. I never believed it till I tested it, and it does work. Management of seizures. The seizures are very common in these patients, and only up to 30 to 40% of them require little longer treatment. Most of them, there is no need for prophylactic AED. They require short-term treatment with AED, and we are also part of currently the PRO-LEVIS trial, which are testing this hypothesis of they require only short-term AEDs by Rohit Bhatia of AIIMS is the PI. The risk of seizures is increased when there is ICH, SAH, cortical vein involvement or the suprasagittal sinus, or when there is edema and venous infarct. What is the role of Dovox in CVT? All these trials have shown us the RESPECT CVT, the SECRET trial and the ACTION CVT, that the dabigatran versus warfarin, rivaroxaban versus standard of care, and here Dovox versus VKA. All these have been tested extensively and they have shown safety. There is no risk of hemorrhage, and reasonably they are all almost equal efficacy. However, we require large trials to make them as the alternative, as the first line of treatment. This is the ACTION CVT trial, which has been done in a large number of patients in a multicentral trial, and it is associated with similar clinical and radiographic outcomes and favorable safety profile when compared with warfarin treatments. Rescue therapies are when the patient does need, we have so many of our endovascular youngsters that we saw today, mechanical thrombectomy and local thrombolysis are also an options in these patients, especially when there is a superior sagittal sinus and transverse sinus, they are easily accessible. And the patient comes with the acute onset raised ICP and there is a large infarct. Our neurosurgeon can do a decompressive craniectomy and to prevent impending coning. These are the two things. They do have a role in the serious patients. And what about long-term management? The optimal duration depends on the underlying risk and we have to investigate them, especially not leave that patient has hormonal therapy, we stop the hormonal therapy and the patient will be all right. No, most of them, they have more than one cause and you must investigate them for the thrombotic profile with the genetic conditions so that we can decide about the severity or the risk of recurrence and the length of therapy. In patients with thrombotic conditions, of course, they require lifelong therapy and duration of anticoagulation for transient conditions is up to 3 to 12 months of treatment. Identifying recanalization with MRV and CTV is not needed and it doesn't guide our length of therapy. And however, the most important point now we know now is you have to follow them up regularly and advise them regarding their future life. And what about the prognosis? This is one of the international CVT multinational multicentral prospective registry which showed that the mortality is about 8% and 5% are disabled. Overall 80% do very well and 15 to 20% have some problems. And they also found that CVT has more than one risk factor and don't stop at identifying one risk factor in a particular patient. And prognosis, in general, it has very good prognosis. They become totally normal despite big infarcts. That 80% recover to normalcy. Acute phase deaths are 5% in those patients very acutely with raised ICP. Long-term mortality is 8 to 10%. Part of it because of CVT, part of it is because of the underlying conditions like malignancy. Recurrent CVT is about only 2 to 4%, but you have to remember to mention it to them and then they should go on identifying these symptoms. The specific considerations in general, DOACs, when and where to give, reasonable to transition to DOACs after a period of lead-in parenteral anticoagulation. Instead of warfarin, we can choose a DOAC, especially in young people where they may not come for a regular follow-up. Optimal candidates for DOAC therapy are still being defined. Ongoing research is there on this. Pregnancy and lactation, DOACs and warfarin are contraindicated in pregnancy. Switching from parenteral to oral, transition typically occurs after 5 to 15 days of lead-in parenteral anticoagulation. Usually we do within 1 week. The duration we already discussed and antiplatelet agents have no role as of now. And pediatric population, it is very common and again neonates are very much affected and they are high risk of morbidity and mortality. Risk factors are commonly congenital heart disease, cancer, anemia. And CVT during pregnancy we need not discuss. And this is one word about vaccine-induced immune thrombocytopenia recently recognized during the COVID period. This is associated with the vaccination of the adenovirus-based SARS-CoV vaccine. And the most important thing about this particular syndrome is heparin is contraindicated. We should always treat with IV immunoglobulins and administration of steroids and avoid platelet transfusions. This is a very specific syndrome where you have to be aware of it. Luckily right now we are not in that particular phase. However, all other vaccines are reasonably safe. We need not worry. As many patients have doubts now, they don't want to take any vaccine. Leave alone COVID vaccine. They are saying, no vaccine madam, that COVID vaccine made me this and that. But in general, except the adenovirus based vaccine, all other vaccines are safe. These are the important clinical points that I have mentioned during my discussion. And to conclude, CVT is, though it is not common, you have to recognize it and with high index of suspicion because it is eminently treatable with simple medicines and they become completely normal, 80% of them become normal. To diagnose, routine CT and CT venogram, MR venogram may suffice. However, when required, you can go for, when in doubt and if the routine imaging is not showing the CVT, you can go for contrast enhanced MRV, gradient echo and susceptibility weighted sequences, which our radiologists are talking about. The DOACs appear to be safe and effective alternative in the secret trial and action CVT trials. Identifying recanalization is not required to stop the thing. The duration depends on the underlying risk factor. Endovascular therapies and surgeries are reserved for serious patients. Despite limited evidence, decompressive surgery can be life-saving in some of these patients. All of us did. I'm sure many of you have saved some patients with decompressive craniectomy. And many patients have underlying genetic or acquired thrombophilia. Please investigate them completely and then advise them regular follow-ups. And my reference will be, there is a very nice scientific statement came out recently in 2024. This is from AHA guidelines. Thank you very much for your patient listening.
Thank you, madam. That was a very quick overview of the topic. Now let's have a quick break, and all the questions can be discussed over the break because we are running short of time.